those in our TBD community to be aware of all the treatments and therapy options that may be available to them. Dr. Myers is an associate professor of pediatrics at the University of Cincinnati at Cincinnati Children's Hospital Medical Center. Her clinical efforts are focused on patients with bone marrow failure disorders, including telomere biology disorders. Her research spans many topics, including bone marrow failure, acute treatment and complications, and therapy late effectives. She is also the principal investigator for Lexogen's sponsored clinical trial evaluating telomere elongation with EXG 34217 in patients with telomere biology disorders with bone marrow failure. She will talk about this and other non-transplant therapy options during her talk. Join me in welcoming Dr. Myers.
Maybe. There we go. Hi, everybody. Feel free to interrupt me as I go through this and happy to answer questions along the way. Many of you know I'm in Cincinnati. I'm going to mostly focus this talk on the gene therapy trial, but I will sort of go over some of the other non-transplant therapies for bone marrow failure, many of which Dr. Bertucci also covered the other day, which is why I'm going to go through them rather quickly, but do stop me if you have questions. So we know, as Dr. Bertucci very well covered, that patients with TBD do develop bone marrow failure, and sometimes this is in very mild and in only one or two cell lines or types of blood cells, and sometimes this can be quite severe and result in aplastic anemia or lack of the ability to make blood. Treatment options for low blood counts. Dr. Agarwal, a little bit later, will discuss the definitive therapy that's currently available for bone marrow failure in patients with TBD, which is, of course, stem cell transplant. Dr. Bertucci very nicely talked about androgens and supportive care, and so I'll concentrate mostly on investigational therapies. I do want to touch briefly on some therapies that have been used in the past, which have included more immunosuppressive therapies such as prednisone or other immunosuppressive medicines. And generally, sometimes some patients still do receive these therapies as they go through their diagnostic journey and perhaps are given the diagnosis of acquired aplastic anemia before the diagnosis of telomere biology disorder. But generally, these immunosuppressive approaches are not successful and can worsen some of the other issues that come along with TBD disease. So Dr. Bertucci covered this quite nicely, but just very briefly, androgens are not generally considered to be curative for most patients, although they can give good responses in telomere biology disorders for many, many years for some patients, although that's not uniform, and they do typically stop working over time. And I listed a couple examples there, but danazol is certainly the one that's most commonly used in the United States. Generally, they don't totally normalize the blood counts, but they do improve them to the point where patients are no longer symptomatic or requiring transfusions. And we know that they don't prevent or delay the development of myelodysplasia or AML in patients either. This is a treatment that's commonly used across different inherited bone marrow failure syndromes, and patients with TBD generally require slightly lower doses than some other diseases. We also covered the side effects nicely yesterday, but they do have significant side effects, including virilization, behavioral changes or mood swings, liver toxicity, which is especially important in our population, as well as elevated blood lipids and effects on growth. And so certainly patients who are on androgen therapy do require special monitoring for these complications. And really the goal is to use the lowest possible effective dose to minimize side effects. Supportive care is also an alternative or can be done together with endocrine therapy sort of in transition. And this does include transfusions as well as growth factor support, including GCSF. Generally, chronic transfusions can be pursued for a period of time, but do result in issues such as iron deposition, potentially needing chelation therapy for patients who are using this as a sort of chronic therapy. This isn't something that generally a lot of patients use chronically these days. GCSF is typically used for profound neutropenia, which is an ANC less than 500, or in the setting of recurrent or serious infections. There is a theoretical risk of stimulating a pre-existing clone, and so the patients on GCSF therapy need to be monitored a little bit more closely. So moving on to more investigational therapies, and Dr. Pertuch also touched on this yesterday as well. There are folks examining the impact of low-dose danazol on telomere biology disorders, not only in the improvement of blood counts, but sort of looking at improvement in actual telomere length, as well as sort of other aspects of telomere disease. And so she talked nicely yesterday about the conflicting data from an initial NIH pilot study and then some retrospective studies that looked at telomere length changes by different methods, by PCR versus flowfish, and then also looked at changes in blood counts and as well as pulmonary and liver function. And so the jury is still out on this, and that's why there's an open clinical trial currently at the NIH for both adult and pediatric patients with telomere biology disorders. And it's important to note, and I think Allison mentioned this yesterday, that this trial is open to patients not only with bone marrow failure, but also those with pulmonary fibrosis and hepatic fibrosis. And they're looking at the rate of telomere length change, toxicities from the danazol therapy, as well as the rate of change of lung and liver and bone marrow disease. This trial, I think we heard, is a couple of years out from accruing and finishing, but an important way to add to our knowledge about how danazol works in patients with TBD. And so certainly encourage patients who are interested in pursuing danazol therapy to consider participating in this trial. Other investigational therapies, I talked briefly about growth factors such as GCSF, but there are medications that work on encouraging platelet development as well. An example of this is eltrombopag, which is a thrombopoietin receptor agonist. And this is a drug that has been used extensively in idiopathic aplastic anemia or acquired aplastic anemia. And in those studies, there were a couple of patients that were later discovered to have telomere biology disorders. And so really this is anecdotal data, meaning only a couple of patients who had sort of mixed results, some with improvement and some without. There are open clinical trials for eltrombopag in Fanconi anemia and diamond-blackfan anemia, but not currently in TBD disorders. And so I'm going to talk more now about a gene therapy trial. I'm not going to go over gene therapy in general. I think that's a whole talk of its own. But there are multiple ways of approaching gene therapy, as we sort of touched on in the panel. Some gene therapy focuses on the hematopoietic stem cells or bone marrow stem cells themselves. And generally, for patients with bone marrow dysfunction, this is thought to fix the bone marrow aspects of disease, but not necessarily the other aspects of multi-system diseases. As I alluded to before, there are gene therapy trials in other diseases that are targeting other organs outside of the hematopoietic system, but not currently in TBD. And so the trial I'm going to talk on more today is a trial sponsored by Oxygen Therapeutics, and This is a trial exploring telomere elongation using EXG34217, which sounds sort of like a Star Wars name, but I'll explain it a bit more in a second. And this trial is only open in Cincinnati Children's as a single-site trial. So this is a phase 1/2 trial, so it's adult only. It is first in human, meaning that the patients enrolled in this trial will be the first humans to undergo this therapy. We're looking to enroll 12 subjects who have Telomere Biology Disorders with mild or moderate bone marrow failure, and I'll get into that in a second. In this trial, bone marrow stem cells are collected from participants and treated to try to elongate their telomeres. We hope that this will give those stem cells a potential survival advantage to maintain blood production for longer in patients who receive this therapy. This therapy is intended to extend telomeres in a telomerase-independent way, meaning that the specific gene that is causing the telomere biology disorder is sort of not the focus of this gene therapy, because the focus is on elongating the telomeres, not fixing the underlying cause of telomere shortening. Another important point about this particular study that was talked about in the panel is that it is a bit of an advantage for patients who have bone marrow failure. If you modify their stem cells and give them a survival advantage, they may not need to have chemotherapy or radiation to create room for the stem cells to grow. And when Dr. Agarwal talks about stem cell transplant, he may talk a bit about sort of the need for chemotherapy to open up and make room for the new stem cells. But in this particular study, and in theory, in patients with bone marrow failure, the need for chemotherapy and radiation may not be necessary, and this particular trial does not include it. The trial includes a mobilization and collection of stem cells from the peripheral blood, and this uses standard medications that are used to mobilize stem cells in patients who are difficult to collect stem cells in. So we know patients who have received a lot of prior chemotherapy, it's difficult to collect their stem cells. We know that in other marrow failure syndromes who have pursued gene therapy as well, such as Fanconi that stem cells are very challenging to collect. And historically, there's some small data in literature to suggest that patients with telomere biology disorders are also challenging to collect stem cells in. And so this particular trial uses both GCSF, which is a standard medicine we use in TBD, but also a medicine called plerixafor, which kind of kicks the stem cells out of the bone marrow environment and circulates them in the peripheral blood. After mobilizing these stem cells, they get collected in a standard way with a apheresis machine, the same way you would collect a bone marrow donor's cells for a standard stem cell transplant. These cells are then treated in the lab with the viral vector, which is called EXG001, and I'll talk about that in a second. And they're treated for 24 hours. And then infused back into the patient. There is follow-up for up to a year for the study, and some of the follow-up is in Cincinnati, and some of it can be done locally with your local doctor. So I used a lot of numbers and a lot of terminology, but EXG001 is a sort of a cryptic name for the viral vector that treats the stem cells. This virus expresses a human protein called ZSCAN4 that is normally present in human cells during embryonic development and is also normally present in human stem cells at very specific times during the human lifespan. We're just using this virus to express it and an extra time to elongate telomeres in these bone marrow stem cells. This virus is not a virus that infects human cells normally, so it doesn't make people sick. And it is engineered to be temperature sensitive, so it shuts off when it reaches human body temperature. And that's important because we want to extend the telomeres for a controlled period of time, because what we've learned is that not only are short telomeres a problem, but very long telomeres can be a problem in patients as well. So after the cells are exposed to this virus, the treated cells are now called EXG34217. I don't get to invent these names. And they are then returned to the patient through an IV infusion. So again, I mentioned this before, but the hope is that the stem cells with longer telomeres will have a survival advantage that will help them work better and maintain blood production longer. And this may help the bone marrow and blood count issues that patients with TBD have. We don't anticipate that this would change other TBD-related complications, such as the liver and the lungs. And I've had folks ask me several times, when discussing this trial, how long would one think that this would last or hold for? And could you get more than one infusion of this type of therapy if it doesn't last for very long? And the answer is we don't know. If it works at all, we hope it does, but we don't know. And currently the clinical trial is only set up for one infusion. But in theory, if it is a successful therapy, you could consider being able to do this more than once. So the primary goal of the study is a phase 1 study, and this is really important because I want to emphasize that this is sort of early stages of looking at this type of approach in patients with TBD. So the main goal of the study is it safe, and do patients tolerate this therapy? The secondary goals are, can we collect enough stem cells to make this type of therapy feasible in patients with Telomere Biology Disorders? We know that it's difficult to collect stem cells, so can we get enough that it's feasible to do? Can we feasibly extend telomeres using this approach? And then sort of last but not least, probably what's most important to people in this room is, do we see clinical benefit? Do we see improvement or at least stabilization of blood counts in patients? This study is an adult-only study at the moment, and that is because it's a first-in-human clinical trial, and for safety reasons, we need it to be adult-only. And patients do need to have really only mild or moderate bone marrow failure. And the reason for that is because we want these collections to be successful, to move the study forward. And patients who have very low blood counts generally have less stem cells, and so they're very difficult to get to collect at this time. And of course, you do have to have a diagnosis of Telomere Biology Disorder, but you don't have to have a known gene mutation. You can have simply short telomeres less than the first percentile. Also, to highlight patients that cannot be enrolled in the trial would be patients with severe bone marrow failure, for reasons that I just stated. Patients who have clonal chromosomal changes or mutations that are concerning for progression to MDS or AML. We don't want to enroll patients that we may cause additional harm to, and the concern is that the mobilization process that GCSF works for may be a higher risk process for patients who have a known higher risk of MDS or AML. Patients who've had a stem cell transplant are not eligible, and patients who have cancer with inactive treatment are also not eligible. Patients who are on danazol or other androgens do have to have a washout period of 60 days. So they would have to stop their medications in order to enroll in the trial.